Welcome. Today, we're going to look past all the clinical tasks to get to the real core of nursing, the stuff that exams like the NCLEX are actually testing you on. This is all about the art of caring, and more importantly, how that art directly translates into keeping your patients safe. So let's just start with a big question, one that pretty much every nursing student thinks about. Is our job just a long list of tasks? Starting IVs, passing meds, and charting everything on time? Is that all it is? Just a checklist to get through before your shift ends? Or is it something way deeper than that? Could it be that the human connection we build is the very thing that can stop a clinical disaster in its tracks? Well, the answer to that is what separates someone who's just good at tasks from a true nursing professional. To really get that connection, we have to start with the why. Nursing theories. Now, I know these can feel a little abstract, but they're not just for writing papers. They are the scientific frameworks that give meaning to everything we do. This is what the NCLEX is testing, not just what you're doing, but the rationale, the why behind it. Okay, so let's break down two big ones real quick. On the left, you've got Leininger, who says that caring has to be culturally specific. The mnemonic here is easy. L for locals and language. Then on the right, there's Watson, who wants us to look deeper, to focus on a person's inner healing and their sense of dignity. For that one, just think W for wholeness and worldview. They're different angles, but see how they're both focused on the entire person? And then there's Patricia Benner, who just nails it. She says, caring is primary. It's not something extra we do if we have time. It's the absolute essence of nursing. It's the thing that lets an expert nurse see past the symptoms on a chart and actually connect with the patient's real story. All right, now for Swanson. If you see a theory on your exam, it's very likely going to be this one because it's so action-oriented. Think of it like a clinical roadmap. It starts with knowing, which means you fight the urge to make assumptions and you actively look for clues. From there, it flows into being with them, which is about being emotionally present. That leads to doing for them, helping with their needs while preserving dignity. Next comes enabling. This is all about teaching, helping them through transitions like a new diagnosis or discharge. And it all leads up to maintaining belief, where you offer realistic optimism. Every single step is a concrete nursing action. Okay, time to put it into practice. Here's a scenario. You've got a new mom, and she's really struggling with breastfeeding. You take the time to show her a new way to hold the baby and explain how the latch works. Looking back at Swanson's list, which one of those processes is this? Yup, it's enabling. And here's why. You're helping her get through this huge life transition, becoming a mother. You're not just doing it for her, you're informing and explaining, giving her the skills she needs to succeed on her own. The real key here is empowerment. That's what enabling is all about. So we've got the why from the theories. Now let's talk about how we do it. That brings us to ethics. Think of ethics as your moral compass on the floor. It's all about navigating that tricky power dynamic that always exists between a caregiver and a patient. This quote really gets right to the heart of it. Let's be real. As nurses, we have knowledge, we have access, we have authority that our patients just don't have. An ethic of care means we have to be constantly aware of that power imbalance so that we never, ever take advantage of it. Okay, let's test that moral compass. Your patient is about to go to surgery, but they pull you aside and admit they don't really understand what's happening, and they're scared to ask the surgeon, who seems really busy. As their advocate, what is your number one priority in this exact moment? You contact the surgeon. End of story. And here's the clinical logic. Your primary duty isn't to the surgeon's schedule, it's to the patient. You have to balance that power dynamic. A signed consent form means nothing if the patient doesn't truly understand. Your job here is to protect their right to know, period. All right, we've talked theory, we've talked ethics. So how do we actually do all this? Let's get into our clinical toolkit, how these big ideas turn into real, tangible things you do at the bedside. Touch is one of the most powerful things we do, but not all touch is the same. First, you have task-oriented touch. Think about the confident, efficient way you touch someone when starting an IV. Then there's caring touch. This is about emotional connection, like holding a hand or giving a back rub. And finally, you have protective touch. This is all about safety, like putting a firm hand on someone's arm to keep them from falling. It's the intent that matters. Another quick scenario for you. You have a confused patient who's trying to climb over the bed rail. You quickly put your hands on their shoulders and firmly guide them back down to sit. Which of those three types of touch are you using? That's protective touch. And the rationale is super clear. Your primary immediate goal in that second is to prevent an accident. It's not about doing a procedure, and it's not about an emotional connection. It is 100% about physical safety. Of course, caring goes way beyond just touch. There's providing presence. And this doesn't just mean being physically in the room. It means being emotionally available. Sometimes the best thing you can do is just sit quietly with someone. Same with active listening. It is a conscious choice. You have to literally stop what you're doing, turn, make eye contact, and just listen. That action alone tells them they matter. So all of this stuff, the theories, the ethics, the specific actions, it's all driving toward one single goal: knowing the patient. And I want to be really clear, this is not about just being nice. This is the critical bridge that connects being a kind person to being a clinically safe nurse. So what does knowing the patient actually mean? It means you have a deep understanding of their unique patterns, their normal responses. You know what's normal for them specifically. And why is this so important? Because it's the only way you'll ever be able to spot those tiny, subtle changes before they explode into a full-blown emergency. This is the absolute heart of clinical judgment. And just look at the difference this makes. Nurse A walks in, vitals look good, the patient is quiet, so she charts patient resting quietly and moves on to the next room. But Nurse B has been with this patient for a few days. She knows this guy is a talker, always cracking jokes. So for her, this silence isn't rest, it's a huge red flag. She investigates and she finds a complication early. Same patient, same vitals, totally different and potentially life-saving outcome. The fallout from not having this connection is very real, and it's measurable. You see more patient falls, you see more med errors, you see terrible discharge plans that fall apart. But the scariest one is failure to rescue. That's when we fail to notice a patient going downhill until it's too late. And that is often a direct result of not truly knowing our patient. So where do you get this crucial intel? Well, your number one resource is often sitting in the chair right next to the bed. The family. They know the patient's baseline better than anyone. It is so important that we treat them like partners in care, not like they're just visitors. And that brings us to one last thought. We spend so much of our time staring at monitors, looking at numbers, but maybe the most critical, vital sign of all, that subtle shift in someone's story or behavior, isn't on any screen. The real question is, are you listening for it?